I'm Sandip Patel. I'm an MD medical oncologist here at UC San Diego Moores Cancer Center, where I focus on early phase clinical trials of new immunotherapy, including solid tumor cellular therapy, as well as thoracic oncology. To be immunocompromised means that one's immune system is not functioning at the level that it normally would. This typically happens to cancer patients who are on chemotherapy, but also can happen for patients who are on chronic steroids or other immunosuppressants. These patients have a heightened risk of infection, and especially during the COVID-19 pandemic, there are concerns that these patients in particular may be at heightened risk for having complications from COVID-19. The COVID-19 pandemic has transformed the way in which we take care of patients, and in particular, our patients who are at highest risk for complications from this virus. This includes patients who have cancer, who have pre-existing heart conditions, diabetes, immunosuppression, lung disease. And so one of the things to ask doctor is what precautions are being taken to maximize my safety as a patient who has cancer and who may be immunocompromised or immunosuppressed from their chemotherapy or their steroids. The vast majority of patients on oral cancer therapy, of which there are two types, there's oral chemotherapy and oral targeted therapy. For those patients on oral chemotherapy, it's worth discussing with their medical oncologist during the COVID-19 pandemic, continuation, dose alteration, things of that nature, in particular if the drug that's being taken can suppress the immune system. Now, for the majority of patients who are being monitored routinely, this will unlikely lead to any changes, as if there were any changes to their immune system, they likely would have had a dose adjustment. For the second group of oral medicines, which are oral targeted therapies, the vast majority of these do not cause low blood counts, with a couple exceptions. And so the vast majority of patients on targeted therapies would unlikely have to change their medicine regimen. I think overall, the key point is to just have the discussion with the medical oncologist and understand how your medicine may affect your immune system and your risk of COVID. For the vast majority of patients on these treatments, especially patients who've been on these treatments for a long period of time, it's highly unlikely that they would need any adjustments to their medication regimen, as it's important to continue their fight against their cancer during this time. For those patients who are about to start their initial therapy against their cancer during the COVID-19 pandemic, there are many considerations in terms of the timing. These include the state of your disease, whether it's something that's been cut out, and now we're talking about adjuvant therapy afterwards. That's something that we discuss as curative intent therapy, and then the degree to which chemotherapy adds to that, or radiation therapy, or with patients with widespread disease, metastatic stage 4 disease, in which the goal of any therapy is to keep the cancer at bay as long as possible. It also depends on the type of cancer one is fighting. There's some cancer types that are much more aggressive and those that actually have a much slower growth. And so depending on the nuances of your particular case, and one of the key aspects of personalized medicine isn't just the genetic testing we do, though that's hugely important. It's finding the right therapy for the right patient at the right time. And I think with the COVID-19 pandemic, one of the questions on when to initiate therapy is an important one. In my own experience and for my own patients, the vast majority of my patients are able to initiate their therapy in a timely manner after a detailed discussion about the unique details of their particular case, with an understanding that we want to maximize their safety during this time. The other point to make is the COVID-19 pandemic is going to be an issue, not just for a couple of weeks or for even a couple months, but something we'll likely be dealing with for a year, maybe 2 years. And so there are very few therapies for cancer that can be delayed that far out. And often the decision becomes binary in the sense that, are we going to do it at all? And I think that's an important discussion to have with your medical oncologist. But for the vast majority of patients, there shouldn't really be a delay to their cancer therapy. There are some nuances in which you may want to delay until the health environment's safer in terms of robust testing, universal masking, things of that nature. But for the majority of patients, cancer isn't going to take a time out during the COVID-19 crisis, and so we can't either in terms of their treatment. For those patients who are cancer survivors and in observation or what we call surveillance follow-up, I think it's important to discuss with your medical oncologist the timing of the scans. The honest truth of it is the majority of the scheduling of the scans for survivorship has very little data, and that's why you'll often see recommendations from professional groups such as NCCN and ASCO suggest ranges such as CT scans every 3 to 6 months. And so if you've been having scans, for example, every 3 months, and the range for your particular type of cancer, which is a discussion you should have with your medical oncologist, is 3 to 6 months, maybe during the COVID-19 pandemic, you're thinking about having a scan interval closer to 4, maybe 6 months potentially. And so there is no one size fits all answer, but having that discussion with the goals of maximizing your safety now that you're a cancer survivor, the last thing we want to do is be overzealous in our scanning program and lead to creating a risk that you otherwise didn't have. The flip side is the reason we do these surveillance scans is to catch cancer early. And so how to balance those two risks is a discussion to have with your medical oncologist. And I think this particular aspect, the frequency of scans for patients who are in cancer surveillance, is one of the areas, at least in my practice, we have made some changes in terms of being flexible around to maximize our patients' safety as we build the health system up in terms of universal masking, universal COVID-19 testing for every patient that walks through the door to make sure they're safe. And so I think this is the one area you can talk with your medical oncologist about a delay, because this is the one area in which there are ranges for which we have relatively equal data that there's no risk to going from 3 to 4 months or 4 to 6 months for the majority of cancer types, though this is a discussion that needs to be had one-on-one based on your unique case.